So, as we enter our second session, I allow myself to introduce myself, and I have been tasked with giving the unpopular other side of the ugly baby. What's happening in these community centers? When you go and you say, the doctor didn't offer me a clinical trial, I went to my community hospital and it just wasn't there. What's going on in that space? Can we elucidate that? Can we shed some light and maybe fix this baby up a little bit? Or maybe tear it all down and rebuild something different? So, we're going to begin session 2, and then we're going to have a break, but I want us to get into this session as we're talking about what is the role of the provider? What is the role of the community institution? What is the role of the advocate in those community spaces? Like, what's really happening here? And so we're going to talk about how healthcare provider communication impacts clinical trial enrollment. I would like to first start by just giving some key points about what's going on in our community. And I'll start by saying this. Most patients get their care in their community. We've heard over and over and over again. In 2017, about 55 to 60% of people of color, of black and brown people, got their care in their community. In 2020, that number skyrocketed to closer to about 80%. And the numbers are less important than the reasons why. When you look at the data nationally, about 70% of cancer patients, U.S. cancer patients, live more than 2 hours away from an academic research center. They're just not close. I was on a panel with a woman from Iowa. She said, I've got to drive an hour and a half to see my oncologist. And if I want a second opinion, it's 2.5 hours in the other direction. And so access is an issue. And patients want to get their care where providers look like they do. We've heard over and over and over again, but less than 2% of oncologists are black and brown, or black particularly. Less than 2%. And the majority of them seem to practice in the community settings. There was a 2016 study from Dana-Farber that looked at where black patients got their care in Boston out of 5 major metropolitan institutions, right? 5 major medical centers. The majority of their patients still got their care at their community hospital. And the reason why is because when I went to that academic center, I sat in the emergency department and no one acknowledged me. From the door to the top floors, nobody looked like me. My doctor didn't talk to me. My nurse didn't. I felt unseen. I felt unheard. So even where there is access, patients may still prefer to get their care in their community setting because that may be where their trusted advisors are. That may be where they feel most seen. And the impact of COVID on all of this, it really still has yet to be elucidated. And so we know that there's some reasons why the community setting seems to get these patients, but there's a disconnect in what's happening in these community settings. The studies show, however, that most community providers would like to, in theory, participate in clinical trials. A great study just came out 2021 that did a descriptive analysis looking at community providers and asking them, if you had the resources and the opportunity, would you provide clinical trials for your patients? And resoundingly, they said yes, because it keeps patients closer to home. It helps us to fulfill accreditation criteria. It helps us to have, to fulfill the oath to our patients to provide the highest level of care. And if we could, we would like to. We would like to give cutting edge and innovative therapies, but there are barriers that exist at every level within these community settings. The cost of infrastructure, having an internal review board, having an EMR that is readily searchable for data, right? Having laboratory systems that can do the precision medicine that research requires these days, right? The nurse, the navigator, the infrastructure to conduct clinical trials may be absent in these community cancer programs. The sophistication of billing and reimbursement for time in a system where clinicians are not incentivized to do research because they have no protected time. So now we invite them to do these trials, but you've got to still see your X number of patients, and you still got to do your surgery. You still got to, gotta. And the institution itself doesn't necessarily seem to value clinical trial participation, right? We know that clinical trial enrollment and recruitment can be challenging. 80% of clinical trials experience some recruitment delays at some point or other, whether phase 1, 2, or 3, there are delays. Right? There's selection bias. We want the healthiest of the sick. And where are the sickest of the sick? They're in their own neighborhoods. And so there are patients who may not meet the stringent criteria for clinical trials. Yet another barrier. And there are concerns about trust even among clinicians. One white male clinician was queried about why you don't offer clinical trials to your patients. And he said, because I'm afraid that they won't trust me anymore. Paradoxically, I think that if I offer them a trial, they're going to think I'm experimenting on them, and I don't want to lose that trust. Right? So the clinical trial perspective in the community is skewed, but there are opportunities. Cooperative groups and collaborative partnerships are important. We are part of the Penn Cancer Network. Our clinical trial enrollment tripled in the span of 4 years of being involved with Penn Medicine, and it comes from having trusted resources and mentors. It comes from facilitating a network of reaching out to our collaborative partner, having a navigator who can help patients go get those trials and come back to that community if they so choose. It comes from having the resources from that clinical partnership. And I think the last point is really that we need not only greater institutional support, but we need our advocacy groups. We need our community partners to stand up and to challenge their institutions, right? Their community organizations and their community hospitals, and we want them to say, our advocacy groups need to say, we want to be involved, we want to be included. Yes, put me on your institutional review board. Yes, I'd like to participate in your cooperative group as the voice of the patient in trial design, right? And so the collaboration truly is key. And the take-home point, I think, for all of us is that when you go to your community hospital, you can ask, how does your community and your academic affiliation, how does it strengthen your research collaboration? How do you get patients into those clinical trials? What is the pathway for me? What does financial navigation look like? And how can I elevate the level of care at this community setting? What is the institutional commitment to that? And that is the charge. When you go back to your institutions and when we take this information away, that we can partner with our biotech space. We need to train community clinicians because they certainly do want to participate in research. They may lack the training or the updated skills to do so. They may lack the statisticians and the resources. And so I think there's some work that we can do to elevate the level of care at the community setting so that we can change the narrative of the community hospital didn't offer me that trial.